Okay, welcome and good evening, everyone. We have very happy to be presenting our seminar for tonight. And while we have got participants coming on board, I'm going to make a few introductory comments. And welcome to Lasers for Pain Management in Podiatry, sharing a global perspective across the pond. And I'm very, very proud to be co-hosting this event tonight with my colleague Steve Sheldon from the UK, who I will introduce shortly, along with the other panelists. And just so you know, the layout today is we're going to have a panel discussion about our MLS laser therapy and how it can work in your podiatry practice. If you would like to enter questions as we go, please complete the Q&A little box at the bottom or the top of your screen, and we will either answer them as we go or leave them to the very end. And we also have got a survey, a feedback survey at the end, where we really appreciate any comments you have about what we talk about tonight. Now, MLS laser therapy, we've got some very varied participants on our webinar tonight. We've got some current users and we've got some other new people just looking at finding out more about laser therapy. But for most of us who have got laser therapy, you find that the laser actually changes your practice. So tonight is about talking about how it can help you and help your patients. So it can certainly grow your business in terms of offering new services and attracting new patients. It can improve clinical results, and we'll hear some of these, enhance your reputation as a leader in your profession, which is very important, increase your referrals, and most importantly, we find that it helps your patients get better faster. Different models of laser that we'll be looking at as well. Now, just before we get started, I just want to say that our speakers from the UK are in London and also in Orkney, which is almost the very top tip of the United Kingdom, and all the way down here in Brisbane and Sydney in Australia. So you can see we're just covering the globe here, which is fabulous. We also have some speakers, some participants from around the world. We've got some participants from Ireland, from Taiwan, from Pakistan, from the United States, from the Czech Republic and the Ukraine. So welcome to everyone here tonight. We know you've come here because you're curious and want to learn some more. So there's our beautiful Sydney Opera House, and there are the a landscape from Orkney. So we just get started. Now, just to introduce the panel, and we've got our Australian, Bron Cooper and myself, and from the UK, we have Kirsten and Steve Sheldon. So I'm going to stop sharing my screen now, and if we can get our panelists to come on and they can share their videos and their microphones, and we can get started. So good evening, welcome.
Hello.
Good morning.
Yeah, good morning. Thank you, Steve, for correcting me. So, Steve, you want to go ahead and say a quick hello and introduce Kirsten? That'd be great.
Awesome. Thank you, Catherine. Thanks for that quick intro this morning. As I say, this morning, but good afternoon to you guys. We're on the coffee at the moment, so I suspect you guys are having a nice cool beer or G&T after this. But yeah, coffee for us still at the moment. We're just starting our week. So yeah, I'm Steve from CelticSMR. CelticSMR Healthcare, and I'm delighted to introduce Kirsten Sinclair of Orkney Podiatry, as Catherine said, right at the tip of the UK. Orkney Podiatry of the Uga Clinic. I never get that right, Kirsten. You'll have to apologise.
Yeah.
Uga Clinic. Let me tell you, Kirsten is a laser superstar. Last year, when we went into lockdown, we started at Celtic doing a number of webinars ourselves, primarily to the UK audience. And Kirsten joined us on a number of occasions and presented some great case studies for us and what have you. So she's been an absolute superstar for us over here in the UK. So delighted that Kirsten is here today representing the UK.
Wonderful. Thank you, Steve. And we'll hear from Kirsten in a minute. I'll just introduce briefly Bron Cooper, who is a pain podiatrist and clinical educator. and she is the owner of Dr. Foot Solutions Podiatry and Foot Gear Clinic, and she has been also a superstar, as you like to call it, Steve, in terms of laser, having been to Italy and trained there with the people of ASA Laser, and Bronwyn has also been a good educator for us here in Australia. So I feel very happy that we've got both of these people that can share their ideas and their thoughts. We've put a bit of planning into this. So just let's get going. Our first question tonight, we just thought we'd run through a few questions and have a look at a couple of cases with our experts here. But the first one is if you could just first introduce yourself and just tell us a little bit about you and what you do. Do you want to start, Bronwyn, for us?
Thank you, Catherine, for your generous introduction. Well, she's already said I'm Bronwyn Cooper, pain podiatrist, because the MLS has allowed me to increasingly move more into the field of pain, and sadly there is all too much of it in our community. So I'm located here in Sydney at Drummoyne on a beautiful bay run, which is an extension from Sydney Harbour that some of you know so well. How long have I been using laser? I'm actually celebrating 5 years, and I have a feeling it's this very date, Catherine, can you believe it? So you better send me a big bunch of flowers or something else better than that tomorrow. So that's the quick overview of me. Thank you.
Thanks, Bronwyn. Kirsten?
Yeah, so I'm Kirsten Sinclair. I'm a podiatrist. I work from Orkney Podiatry, which is my own business, and I'm based in the Hooga Clinic, which is also a clinic that I own. I've had my laser now for about 2.5 years, and I can safely say that in those 2.5 years, it has completely changed my practice, like you said, Catherine, and I honestly think it's the best thing I've ever done for my clinic. So really happy that I chose the laser, and also really happy that you've asked me to be here tonight. So thank you.
Oh, thank you so much. And we look forward to hearing more about this. I mean, when you say changed your practice, can you just give us a little bit of a summary of what that means?
Yeah, so like Bronwyn says, it allows us to focus more on MSK conditions. It's given us a tool to use for those really tricky patients, and I'll explain a bit more about that when I present my case study for you. It's just, I think it's given us a much wider scope. Yeah, and I have to say there has been a change in that it has increased our income as well, just giving us that new treatment modality. Yeah, it's been a bit of a game changer for us, and I love using it, which is very important too, I think.
So why did you choose the MLS laser, would you say, you think? That's a question to both of you, actually. Bronwyn, feel free to answer that too.
Well, I'll kick off then if you like, Steve. I hadn't even bothered researching lasers terribly well. I just jumped straight in, boots and all, because I was at a chiropractic conference, our national conference for one of the chiropractic groups in March 2016. And because I'd already been using a different treatment approach within podiatry for some years, some of it for as long as probably at that point 10, 15 years, in relation to different foot gear and different approach to orthotics. This laser was the only one in the trade display, but I had been aware of lower level, like milliwatt units, handheld, all of that. And when I actually saw where the technology had moved on to, because I must say at that point here in Australia, they weren't in our trade conferences terribly much at all. Even now, some of the bigger companies that do have some other laser units are not necessarily displaying those at conferences. So therefore, it was relatively invisible to me. But as soon as I saw the MLS and realised that I had there in this machine the opportunity to be able to introduce patients to change in pain in many conditions at the first visit and not waiting for them to be feeling better as they walked out of the room, that was the game changer for me. So that's why I chose the MLS.
So
what about you?
Yeah, I had actually, I don't know that I was actually looking for a laser at the time, but I had seen the MLS laser mentioned in some of our UK podiatry Facebook groups. All good things that I was hearing. So I contacted Steve just to make some inquiries, and of course after speaking to Steve, how could I refuse? It was really good to get a chance to try the laser first as well. We got a 4-week trial period, which was great. I was looking to add something new to the clinic, and the laser really appealed to me because at the time all that I had kind of as an additional treatment for MSK patients was a shockwave machine, and it really hurts. So the idea of having a potential treatment for patients that didn't hurt was really appealing to me, and I dare say to my patients as well. I was looking for something that would make me stand out above other podiatrists locally, to give me something different, to offer something kind of really up to date and effective. And the laser really ticked all those boxes. It also has such a wide scope of treatment, you know, from MSK work to wound healing, potential for fungal nail treatments. So obviously in a clinic, one machine that can do all of those things is a great bonus. I also like the fact that the MLS laser can do a dual treatment, so you get that kind of pain relief and you get that anti-inflammatory effect, but you also get the tissue healing and regeneration, tissue regeneration as well. And I also like the fact that the MLS laser is really safe to use. You'd have to try really hard. You'd have to really not like someone to cause any damage with it. So I really like the fact that it is pretty much completely safe to use as well.
Oh, so what kind of results do you see in your clinical practice, just generally, that you find with the laser?
Okay, so I see really good results. It's blown a few minds, including mine and my patients, and generally really quick as well. You know, very often we see an improvement after the first treatment, which is just fabulous. I lasered my own wrist on Thursday night, really sore wrist, just a kind of a flare up. It's a stress related thing, and I think after a day in the clinic, it just hadn't helped it. So I lasered it when I finished my clinic, and by Friday it was completely pain-free. All the clicking and cracking had stopped. So really handy tool to have to use on yourself as well.
And probably your family members as well.
Absolutely, yeah, absolutely.
So in a podiatry practice, what would be, say, the top 5 conditions you might use the laser for?
So in our clinic, it's definitely more MSK type conditions that we're treating with it. Things like plantar fasciitis, Achilles tendinosis, arthritis, anywhere really, bursitis as well, hip bursitis, and just general tendinitis, I would say, would be our most common conditions. But I know that Bron has a wider range that she's using it on at the moment.
I think some of those ones are very core conditions that the laser works. And so, Bron, what about you? What sort of results are you seeing with the MLS?
The first thing is, I neglected to say earlier about why I chose it. The hands-free component is such a plus, because in effect, in my unit sitting there behind me, as you can see, so you've got the big Charlie head with the 3 diodes, and you can do big joints. And you'll see from my case that I present, which is an interesting one, who had 3 different problems. When we get to the cases, that it's really possible then to be able to treat the knees while I'm still treating, in her case, a bilateral plantar fasciitis. So you're freeing up your time, but your results, and that's important for patients these days, not just we clinicians, but your results are almost too good in some respects. Now, does that mean that laser, and particularly the MLS with its dual wavelength and its pulsed setting for the pain relief in conjunction with your healing wavelength, is that really possible to improve everybody and heal everyone? No, of course not, especially with nerve pain, fibromyalgia and all sorts of things. And yet I have had some outstanding results in some of those areas, including a post-herpetic neuralgia. So in my introduction, I did neglect to say that I run some online clinical education, and I'll certainly put that post-herpetic neuralgia case into the webinar that I'm offering later in the month for people, because people are really interested in seeing what happens with those very tricky cases. Fracture pain in podiatry, we don't typically see that much, but I have seen cases of people 48 hours after fracture, even just with a comminuted fracture, the proximal phalanx in the toe, you know, you'd all think, oh, man up. it's not that bad, it's just a little toe. But and I wrote that one up in our national podiatry magazine here, Catherine, you might remember, back in the Australian Podiatry Association June issue of Stride magazine, or was it the July? They featured two stories. So, you know, arthritis, as Kirsten said, and all of the itises, it's really quite a standout. But neuropathy and other things that you can't always help, but frequently can help from the very first visit. And quite a few nerve pain patients leave feeling better. So hematomas was another one, and there was a huge one of almost the entire calf that also was written up with the photos in our national podiatry magazine. But, you know, I never expected that someone had limped in with, without their 4 sets of imaging for 13 years of heel pain would have immediate change in a pain on that day. But those of you who are experienced clinicians like myself will know that you get a gut feel too for what might work for some patients. And I just had the good sense to feel this lady was going to do really well, despite the fact she had not done well anywhere else with physical therapy colleagues, podiatry colleagues, cortisone injections and the lot. And I got my staff member in, we actually filmed that. So that's another one of the complex pain ones that we show. So I don't see a lot of wounds in my practice. I know wounds are just great for, you know, infrared light, energy, etc. Phlebitis I've treated and a few other vascular things. But I think that's probably giving you a bit of an overview of most of it.
Brilliant. Thank you, Bron. Actually, Bron, if I can stay with you for a little bit longer. So you mentioned there you got some cases you might want to share with us. So any good case, what's the best case you're going to, or a good case you might want to share with us today? Or share?
So look, I've chosen a case that is, I think, really typical of the sort of person that walks in, limps in to most clinics, whether it's podiatry or physio. So this lovely 65-year-old presented in November 2018. So a woman who came in presenting with bilateral foot pain, which was actually plantar fasciitis, and knee pain, and her knees felt unstable and clicky. And she was doing Zumba classes at the time that had extremely poor balance. Now, just by way of background, the biomechanics, you know, she wasn't excessively pronated, range of motion was within normal limits at all joints, her gait was good. She had a nice soft landing, a nice short stride. She wasn't overloading anywhere. On examination, she had a positive windlass test, so that was only low grade though. It wasn't anywhere near as severe as that woman of 13 years history of heel pain. Now, her knees were unstable and a bit clicky. And it was only, and this once again is typical of what happens in our practices, it was only when I was carrying out treatment, and incidentally I was able to use the Charlie head on her knees. And to manage time in these cases, I often explain what we're going to do and get their permission to do that. And in instances like this, where there's multiple areas to be treated, I'll often then start on the knee while I'm then examining one of the feet to save time, for example. So there's a number of practical ways you can manage that when you've got the luxury of at least having a hands-free laser. Now, the biggest issue was when I got round her ankles with my hand, she said, "Oh, be really careful, really careful. I've got a really painful area there." And when she pulled up her slacks, there was a huge, what looked like still a hematoma from 13 months prior. So in the October 2017, she'd had a fall in the night down some stairs and had a huge hematoma, but they were going to Uluru in the middle of Central Australia for their wedding anniversary. So off she went and, you know, tried to ice it as best she could, but didn't get good treatment. Now that ended up ulcerating. She had a huge hematoma, so I didn't know her in that stage. Huge hematoma, ulcerated, and had to have care back here in Sydney. Now, I've presented this somewhere before, but if you can see there the spacer of the Charlie head up above, and there's the light centered, it doesn't show the discoloration as brilliantly as you would see if the Charlie wasn't running and perhaps the ordinary lights are on. And look, that's where the ankle is. That's where the kinesio tape drape that I was using for plantar fasciitis, okay? Now, this woman, it was almost like allodynia. It was so painful, you couldn't even just touch. I'm just sitting and resting on the skin. That was too painful to do that. So what happened was she came back 5 days later for the repeat sessions for her knees and feet, and felt so much better there and was confident to then have me treat this long-standing, in effect was scar tissue adhered in behind the tibial crest, a really, as you know, avascular area. So I repeated all that plus the shin. Now the shin felt different and better immediately. Still didn't touch it with kinesio tape, which I wanted to do, until the third visit, which remember was only her second for the shin. And at that point, I did a taping technique where you actually go adjacent to and around the old hematoma and the scar, didn't even go over the top. Now, this just kept improving. So the intervals were 6 days between the first and second knee and foot treatments, then 15 days. I think she was away or something. It would have been preferable to probably have her in more like 5 or 6. Her knee was so much better. She was just stoked. The fourth treatment and only the third of the shin was just before Christmas in 2018, 9 days after the third treatment. Now, the shin wasn't even painful at that point, and I had been able to, at the second shin treatment, just gently mobilise the tissue a little bit. I did a stronger mobilisation on that 22nd of December. Now, she followed up again in the 18th of February and the 28th of March. So the intervals, you can see, are spaced out a bit because she was just so stoked, and we got to the point where that made an absolute huge difference. And the point about this is that a lot of people in our practices have other issues that we don't know about. They don't know that you can help them often, and because no one else had, without having laser. Now, she happened to then present, I had another session with her on the 1st of May, and 4 days later, she presented again, 6th of May, 2019, 48 hours after another injury, nothing like the fall down the stairs. She just was barefoot and caught 2 of her toes either side of the sharp edge of the leg of the chair, and was in absolute pain and agony for the 4th interdigital space there with a huge laceration. And the treatment was so effective, and the taping and everything else we do at those appointments, she didn't have to come back for another 5 weeks after that she came back. Now, I contacted her today because she's moved out of Sydney, not because of COVID. You can actually see the scar from that original injury. She was kind enough to send that through. I've suggested she have an annual review, and I can send her to somebody up in her area if she can't get back to me. She will come to me anyway. So, the story there was her balance was absolutely shot because of not so much the knees and the feet. It was a combination of everything, but really it all emanated from that dreadful injury that I hope we saw well on the screen there. And then you can see that when she had an acute episode, banging her toes really badly on the chair, she knew exactly where to come, and in she came again. So I thought that was an interesting case because we all have people in our practices like this.
Absolutely. Thanks. There's a bit of a delay there. I put myself on mute. So that's great. Thanks, Bron. Really interesting. Thank you very much for sharing that. So, Kirsten, have you got a good, interesting case you might like to share with us?
I hope so.
I think it's a bit of a leading question. Like I didn't know.
I have chosen a case which I think is, I tend to call them heart sink patients when they come in, and you've kind of thrown everything at them, nothing's really working, you're like, oh, what am I going to do? So this patient, and she first came to see us in kind of early 2018. It started off with a right-sided insertional Achilles pain, and insertional Achilles tendinosis can be a bit of a nightmare to treat. She was 32 at the time. She was hoping to train for a marathon. She'd been doing a lot of running just for fun, really for health and fitness, and maybe the social side as well. She had started doing fun kind of competitive 10Ks and things like that. She also had a little dog, and she enjoyed walking her dog. Her pain was at the stage when she came to see me that it was preventing her from doing any of the things that she enjoyed doing and that she wanted to do. However, she could cycle, so at least she was able to do some cross training. Her pain had initially started after she'd run a 10K and had an on-site massage immediately afterwards. That's what she was blaming. But she also mentioned to me that she'd changed from a Hoka running shoe to an Asics, and I suspect that that was a big part of the problem, because there's just so much more of a heel raise in the Hokas, and the drop had been too much and it irritated that insertion point. So when she came to see me, she was scoring an 8 out of 10 on the numeric rating scale, the pain scale. She was walking on her toes because she was completely unable to put her foot flat. It was just too painful for her. She'd had to stop running completely, and her husband had taken over the dog walking, which was very frustrating for her, because I think the fact she'd built up to the level of fitness that she was at and was able to cover the miles that she was covering was quite an achievement for her. So to not be able to do that anymore was kind of getting her down. So after taking her history and doing an assessment, we just started her off with some exercises. We gave her heel raises in her shoes, not her Hokas, but her kind of day-to-day shoes. She was using topical anti-inflammatories on the area of pain. We modified her activities where possible, avoiding walking up hills, things like that was going to put extra tension on her Achilles. But we discovered that her problem was extremely irritable, and we ended up at the state. Heel raises were one of the exercises that I'd given her. And we ended up having to get her to do that while she was seated, because it was so irritable, and even doing that seated was setting her off. So she was a really, really tricky case. Taping did give her some relief. She managed to get in a couple of pain-free dog walks. She was also going to a physiotherapist who was throwing everything at her: massage, cupping, an electric shock pad underneath her foot. And all of these things gave her slight relief, but ultimately none of it really stuck. So I was at a bit of a loss with her. We tried kind of everything in our toolkit almost, but we weren't really getting anywhere. And the last thing that you want to say to a patient is, sorry, you're going to have to stop doing all the activities that you really enjoy doing. It's the only way you're going to get better. But that's kind of where we were at with her. So by August 2018, her left Achilles was starting to niggle as well. At the time, I had shockwave in my clinic, and so I had mentioned to her previously that the shockwave was an option, but shockwave on an insertional Achilles tendinopathy is really not pleasant. So we'd kind of tried to do everything to avoid that. But we were at the stage thinking, this was what we were going to have to do. But she then fell pregnant. So we didn't do any further treatment at that time, because she'd just stopped her running really. And we hoped that that bit of a rest would kind of reset her and she could start again. So she had her baby in June 2019. She'd had her rest and her Achilles was feeling okay. But of course, she wanted to go back to running again. That was kind of later 2019, early 2020. But she, of course, when she started upping her mileage, felt her right Achilles starting to cause her problems again. This time her pain was about 5 to 6 out of 10 when she came to see us, but she had the fear, because she'd struggled so much with it previously, that when she felt it starting, she knew that she needed to come in to see us to get something done about it, hopefully to allow her to continue with her running. By this time, we had the MLS laser in the clinic. Hooray! So we decided to do a course of laser treatment for her, something that would hopefully be effective and much kinder than the shockwave that we'd previously discussed. So at her first treatment, so in our clinic, I should just mention here, we do treatments 1 a week for 4 weeks as an initial course. It just works in better with our appointment availability and things like that. We tend to do a full treatment every time. So we do a scan phase, a pathology phase, and trigger points. So at her first session, we treated her with an acute pain foot scan phase. We did an Achilles tendinopathy phase and 5 trigger points, which were mostly around the medial aspect of the insertion, which is where she was feeling the bulk of the pain, and also up into the calf muscle. And she noted that her discomfort felt immediately improved after her first session. So the signs were good that we'd found something that was going to work for her. When she came back for her second session, which was 7 days later, she said that she'd felt really good over the past week. She'd even managed a couple of 2-mile runs, which hadn't caused her any problems. So we just repeated the same treatment again, because it had been effective for her the previous week. when she came in for her third session, she reported that she'd had a wee niggle, that's how she described it, a slight niggle over the previous week. So we repeated the treatment again, but we just put in a couple of additional trigger points for her. Her fourth session was cancelled because the UK went into lockdown, so we weren't able to see her. So that was really the last that we'd heard of her, but we knew that she'd responded really well to the laser. So I actually called her yesterday ahead of the presentation today, just to see how she was getting on and to check that I wasn't going to do a presentation about something that was actually a lie. And that this had been another thing that hadn't stuck. When I spoke to her, she told me that on Saturday she had done a 10-mile trail run with no problems, and I've also seen her name popping up on our local park run a couple of times with sub 30 minutes for a 5k. So she's doing really well, and she's really happy. I think, and for me, being happy is you know, equally as important to her being pain-free, because it's all part of the same thing, really. So yeah, laser treatment really helped this tricky and really irritable case of insertional Achilles tendinosis, and I'm really glad that we didn't have to shockwave her.
No, that's great, and thank you. And you know, listening to yourself and Bronwyn there, I mean, you know, from my personal experience, when we introduced the laser to the UK, you know, over 3 years ago now, you know, you talk to people and the advice would be, you know, you've got to get in with the high-end sports clubs, you know, the high-end, you know, the top-end athletes and this, that, and the other. This is where it's brilliant. But it's, which is great, of course it would be. It'd be lovely to have this in all the top football clubs and rugby clubs in the UK, of course it would. But actually, you guys, you're seeing ordinary people every day just want to go about their lives, a normal day-to-day activity, telling someone to stop walking the dog, you might as well chop their right arm off. You know, it's important to them. So that's what's so great to hear. And obviously, hear some great examples from you guys this morning, or this afternoon, I should say, the evening and this morning. I'm never going to get my head around that. But you know, we see it all the time on our laser forum, don't we, Kirsten, over here in the UK, and just of the users out there. Just another great example this week where they had this person, you know, a brief outline, and now they're doing this, and they couldn't do this, and we did this, we tried this, and now we fixed it, so to speak. Just, you know, we could write a book, quite frankly, couldn't we? The examples we see all the time. So I just wanted to.
Can I throw something in there? And because there's questions coming in, I'll put the glasses on, because someone's asked how you can work. Yes, you do have to use special glasses that are appropriate for each class of machine. But yes, I can do work, including it in some instrument work, with eye protection on. But I just wanted to let everybody know that there's a brand new bit of research. There's lots of research out there, but a new bit on Achilles tendon injury in an experimental model in rats. It's out of Brazil. Catherine may have seen this. It's not even yet in the print publication. It's the Histology and Histopathology Journal, March 23, 2021, really current. This is where you can't see the colour very well, actually, when you have got the coloured eye protection on. So to pick up my yellow highlighter, what they did was they partially severed the tendon on the right leg of the rats, the poor rats, and used the left as the control. And of course, it conclusively showed that the PBM, or photobiomodulation or medical laser, effectively interferes with the tendon tissue repair after injury by stimulating the mesenchymal cell proliferation and synthesis of collagen type 2, which is suggested to provide structural support to the interstitial tissues during the healing process of the Achilles. So, you know, once you're in the laser fraternity and you start picking up on all these bits of research, it's just fantastic. And my last little bit there, I was absolutely chuffed to finally have a patient with an Achilles tendon injury of 14 months come to me last week that had failed PRP, blood platelet injections, and physical therapies and lots of things. And one of our most senior sports physicians here in Sydney, Australia, at Olympic Sports Medicine Park, had suggested that he could consider either shockwave or medical laser. So I've already spoken to that sports physician on Friday, and I'm hoping to set up a time to connect with him, because he did say he thought high power, which he told him the physios at their clinic didn't have. So just want to add that in to cement what you've just said, Kirsten.
So thanks very much for those comments. So interesting, really. Just a few points I'll just pick up while we're here is there's certainly a lot of research available, and we can furnish you with any of that, you know, where's the evidence, where's the science behind all of this. I know we're talking about case studies and practicalities, but Bronwyn's exactly right. There's some very rigorous clinical studies, clinical trials coming out all the time. So we can point you in that direction. I love hearing about from both of you, Kirsten and Bronwyn, you clearly have a long-term relationship with your patients, and you know, you're really trying to help them improve their lives, the quality of their lives, talking about the relationship between pain and depression and how they live, I think is, you know, it is a testament to you that you spend so much time with them. And also, Kirsten, you know, I was interested that you would treat them once a week for 4 weeks. You know, I think that's the thing. You have to be practical in how often people can come in and how often you can make yourself available. Yes, the ideal world might be you treat them with laser every other day for a couple of weeks, but practically, you know, not everybody can manage that. So one of the good things is you can still vary the treatment regime to suit you and to suit the patient and still get results. So I think there's a lot of flexibility with laser, which is just really great. Now, just moving on, so Kirsten, what would you say to other podiatrists thinking about this? I mean, you know, this is something that I get a lot of questions from podiatrists or clinicians or physios or anyone really trying to deal with pain is, you know, why should they look at laser, do you think? What would you say to them?
Okay, so I regularly recommend laser to people. It's the best thing, like I said earlier, it's the best thing I've done for my practice to date, I think. It gives you a tool for those end of the line patients who've tried everything else, you know, in podiatry, that would be that patient that comes in with, you know, a bag of 12 pairs of insoles, and you're like, oh no, you know, what am I going to do with this person that nobody else has tried before? So your laser gives you something to use for those people. It gives them some hope that there is something else to try. I think from a practitioner point of view, it's actually really enjoyable and simple to use. I just call it like a point and shoot tool, because you literally, that's basically what you do. You know, it's so intuitive to use. But equally, you know, you get those heart sink patients, but you also get patients like Bronwyn said, where they maybe go, oh, by the way, I've got, you know, just this little thing that's niggling me. You know, I had a patient and she just comes into me routinely just for routine podiatry, you know, nails and calluses, that type of thing. And she mentioned that she was having problems with arthritis in her ankles. So I said, you know, let's just stick some laser on it and see if it helps you. You know, and it did. So it gives you something that you can use on those patients as well and open up their eyes to it. And that can then lead on to them coming in for, you know, a proper course of treatment rather than just a little taster session. And yeah, and like I said, it doesn't, well, certainly in my case, and I'm sure most people who've taken on the laser, it increases your income as well. I mean, ultimately, when you're running a business, you want to be earning as much as you can. You want to be able to pay your bills. So from a, you know, a business owner's point of view, it's been a boon from that perspective as well.
And one of the things you said earlier was when you were looking at the laser, was you wanted to stand out. Has it helped you do that?
It definitely has. It definitely has. There aren't any other podiatrists up here or any other, you know, there's no physio or anybody who has a laser. People are very impressed when they see it. Quite often they come in the clinic and they go, what's that? You know, and they see it sitting in the corner. So that opens up a conversation then, you know, to be able to tell them what it is and what it does, what it can be used for. And yeah, we put it out on our Facebook page as well, so that attracts a lot of people to us, because again, there's nobody up here that does anything like that. So yeah, it definitely helps us kind of stand head and shoulders above other people for that type of treatment.
Okay, that's a nice summary. Bronwyn, what about you? What sort of things would you say to a podiatrist or a clinician thinking about laser and bringing it into their practice?
You're on mute.
But you need to put your
We wanted to say
microphone.
that just all morning.
Thanks, Bronwyn.
All right, I got rid of the swear words off screen. Okay. I'm laughing at a couple of the questions, not at the questioners, but no, finance. Kirsten has mentioned finance. So, you know, sometimes people say, oh, I can't afford it. Now, that was the first thing I thought of. So when people say that to me, I say, that's what I thought. And then I stood there and looked at it and I thought, but how can I afford it, right? I turned it around because I realized the potential of this. Now, the potential of this device, and what we're talking about here is the newer technology, high-powered pulsed frequency, and it's just more expensive if you go for the hands-free. But as our practices are full of people with multiple problems, hands-free is definitely the way to go, but you could start at any level. Some people later upgrade. I would just say that what you'll discover is you'll get a whole new lease of life in your practice, and you'll be doing more for your patients than what you ever dreamed you could be doing. And you're going to really get into that field where you're able to treat nerve pain. And wounds, as I said, is not a big thing in my private practice, and I understand generally in private practice where you are, that's the same. I've seen questions on there about scar tissue. I had a woman in today with what I hate calling it Haglund's deformity, but Haglund's syndrome is better. Back of the heel, that nasty bump, Catherine, and a whole lot of adhesions like you saw in the clinic in Italy when we were on that study tour. You know, the thing you've got to remember is that you're really able to take your practice and your treatments to the next level. It will pay for itself and ultimately become an income generator over and above that. At first, you just don't even have to worry about that. It's just like when your patients realize what it can do, they can refer in so many other people that have got problems that you can now help. And there are things that you might not have traditionally thought that you'd help. Look, a classic for me is knee osteoarthritis. And I've been helping that with different foot gear since about 2005. So, you know, we all know that what we do with some orthotics changes, even people's back pain and other things. But, you know, we're now working at cellular level to settle inflammation and change the physiology around pain pathways. So does that answer the question, Catherine?
That's great. Thank you. Yes.
Thank you. And Kirsten will second this. You were wearing the glasses earlier. You'll be my friend for life. I'm always bothering the Aza Laser superstars over here in the UK for a selfie with the glasses. So thank you, Bronwyn, for styling out the glasses so beautifully. The other thing I always ask my Aza Laser superstars over here in the UK is 3 words that describe the MLS. So Kirsten, back to you. 3 words that describe the MLS.
Does couldn't be without count?
Okay, that counts.
But I would actually, in all seriousness, I would say effective, because it is, kind, and I'm going to class this as one word, game changer. Those would be my 3 words /4.
Brilliant. No, we'll take that as free. That
Thanks.
game changers allowed. Thank you, Kirsten. Bronwyn.
Okay, mine are not dissimilar. Immediate, analgesic, unique, because that's your hands-free and your dual pulse wavelengths, because it's got to be the right wavelength, the right dosage, guys. And I've got life changer. You said game changer. Now, how is it a life changer? It's a life changer for both you, the clinician, but they're not interested in that. It's more important. It's a life changer to the patients. And someone put a question or a comment about some effective treatments they're doing in the chat. And, you know, weekly and twice weekly can be too much for some people. And that's quite correct in terms of their hip pocket, although private health funds and Veterans Affairs in Australia and a lot of people have, in my practice, have third-party reimbursers that pay for part of the treatment. And third-party insurance indeed pays for the whole lot, as in motor vehicle accidents and, you know, workplace injuries, etc. So really the thing that I find is that in the big picture, it saves people money. It also saves them time. So I don't have that many people that sign up to a program of 4 to 6 treatments, which a lot of clinics run at a discounted rate, which would be a damn good idea. The laser is almost too good. Sometimes people actually don't need those 4 treatments. I do a lot of 2 treatments only and then follow up a little bit later on, but it just depends on the problem.
Thank you.
Unmute. That's really great. And just one little summary question, and then we'll back to the panelists, and then we'll look at some of the questions people have been asking. But what do you say to patients? How do you talk to patients about it, Kirsten? What do you tell them that they're going to experience, or what's it all about if I'm a patient coming into your practice?
Okay, so if someone comes into my practice and they have a problem that I think the laser would be good for, I tell them I've got a laser for that. And that usually leads them to ask me questions then about, oh, what's the laser? You know, what's it for? How does it work? So the first thing that I usually tell them after I let them know that I've got the laser is that the treatment doesn't hurt, because I find that when patients are in pain, they come in and they're worried that you're going to do something that's going to hurt them more. So I tell them that the laser doesn't hurt. It's very unlikely that will make anything worse, and that it's definitely worth a go. You know, it's not going to cause them any harm. Let's try this and see what it does for you, and you know that it works for 85–90% of the people that we try it on. I might then give them some cases, some examples of where I've used the laser. You know, if I've had a patient in with a similar condition to them and the laser's been effective for them, then I would talk to them about that, that it worked for that patient. And I would focus also on what it allowed that patient to do. You know, it may be that, you know, when the person I'm telling them about had come in, we'll use my case study there. You know, she hadn't been able to run, she hadn't been able to walk her dog, but after the laser, she was able to get back to doing those types of things, so that they can realize that having the laser treatment could change that for them too, and get them back to doing the things that they want to do. I also explain to them, this is usually where they regret asking me the questions, I explain to them that the laser works in two ways, to reduce pain and inflammation, and also to encourage healing and tissue repair. And quite honestly, some of them do ask me for more detail than that, so I will give them the cellular chat if they want it. I tell them that it can work almost instantly for some people, but they may need a course of treatments because the laser has a cumulative effect. So each treatment builds on the last one. And quite often I give them a little taster session, you know, if it's appropriate, if they're in, like my lady with arthritis in her ankle, I'd give her a little taster session so that she could see how it felt. And then if she wanted to book in for a course after that, then she could.
Wonderful. Okay, that's excellent. Thank you for sharing that. Bronwyn, what do you tell? How do you talk to patients about it?
For a start, MLS or the distributors give us good support. So here's one of the documents that people don't have time to sit and read in advance, unless they come super early and I knew I wanted to laser them. I tend to give them that when they leave. Depends on the person, as Kirsten said, and how much they want to know. Generally, they don't want to know that it has a photomechanical and thermal and chemical effect at cellular level. You know, to increase vasodilation and all that. I often just use the analogy, depending on the age of the patient, of, hey, you remember, you know, your folks or the footy coach in the 60s and wherever earlier than that, the 70s, had an infrared heat lamp, and most of them know about that. And I said, right, infrared energy, this is wavelengths of light for healing and pain relief at that end of the light spectrum. You know, I had a new patient today who was absolutely fantastic. I mean, he just made up his mind in about 2 minutes. And I say, yes, no known side effects, pain, unlike cortisone injections, no, not painful, unlike injection shockwave therapy. So, you know, you just gear it to the person. I don't offer them immediate pain relief, but so many get it. And in my clinic, I use things, as you know, as we all do, to offload an area like a painful Achilles to elevate the heel. I will actually get some patients before their treatment, if I think it's going to change the pain, I'll tell them and I'll say, I want you to try something on first, because this is going to help relieve your pain by offloading this painful area. So I just want you to try this first. I'm talking about a form of footwear, and then we do the treatment. And that way we know how much of it's come from the laser. And if you're implementing the two things together, it's like a compounding bit of interest. So yeah, I have had less than 5% of the people I've wanted to use photobiomodulation therapy on not proceed, and you respect that because you don't know what their past experiences are. Something's clearly happened in their life. Most of them do go with it, well, most of them, 95%, yeah. As I said, most of them I give the handout to read when they leave. And I even refer some of them. People ask me now about, you know, the effects of chemotherapy, for example, inducing chemo induced neuropathy and so on, and their friends are put up with so much crap as a side effect from medical treatments. So, you know, I often refer them to Google Scholar and tell them how to research some stuff and let them know I can refer them on to medical practitioners and others using therapy. So that's probably it in a nutshell.
Okay, that sounds really great. So thank you to our panelists for this conversation. Let's switch to a few of these questions and we'll just work through a few of these. How's that sound, Steve?
Sounds good.
Yep,
Yeah.
okay. There's a few questions here. There's a few questions here about cost. What I suggest you do on that in relation to those is speak to your country distributor or person there, because they vary across the world. Also, there's a whole range of different models, from a portable unit all the way up to you can see behind me, there's a robotic scanning laser. So it really depends on what model you're getting, what's the power of the unit, and a few of those things. So that's not a straightforward question to answer tonight. Can we just run through some of these questions? Let's see. Where's
And if it helps, I've already had a bit of a quick look, and some of them will be fairly quick answers.
Let's go for it, Bronwyn.
So
Yeah.
Rosalind, starting at the bottom, how long is each session of laser treatment in minutes? You can do a trigger point in 20 seconds or less.
Mm-hmm.
And I usually have a new patient appointment of 45 minutes. So the woman had both plantar fascias, and that acute condition resolved, my case, in 2 sessions. But I can kinesio tape, and I use the foot strengthening orthotic and all the other things. Knee treatments, because she was coming back then to the shin, I treated all the other things, but mostly it's a 30-minute follow-up for those people. So it depends. At standard, I'm 5'8" most people are going to be a medium-sized build. A small body will be a little bit shorter time, and it also depends on skin type. But the reason that we invest in something that's really quality, like MLS, what you pay for is what you get. It actually tells you the times, etc. The dosages are preset. You can still put in your own. So all of that. Yeah, so the one about successfully treating diabetics, absolutely, because you're touching on your vasodilation, increasing circulation and calming down irritated nerves. So diabetic neuropathy and non-diabetic neuropathy, I've had some good successes, and even a Charcot foot that I'll feature in my complex pain cases on the 8th of April, which hopefully Catherine will be telling you about, which is a free webinar if you put the code from tonight, but we'll tell you about that. I'll leave the fungal nail to Kirsten. Diabetic wound and plantar fasciitis, yes. If you meant that the wound was in the same area as the plantar fascia, you know, you could do the higher setting for the wound healing, and you'd probably get the benefit for your plantar fascia. Obviously, with a wound, you've got your hands free, so it's away from the wound. You don't have the direct contact. You can otherwise put glad wrap or just hold off slightly. I'll just move the box smaller off the skin just slightly so that you're not contaminating a wound. But especially in times of COVID, you know, the hands free can be quite useful. Because I know there's up to about 20 questions there, Catherine.
Yep, that sounds, I think what we'll do, seeing as how we're just about to wrap up, any there that, Kirsten, that stand out that you could easily answer for us?
I'll just say Tony's answer to a couple. I don't know Tony. I don't think I know Tony. So thank you, Tony. It's been a good response from Tony there, I believe. Only know you as Tony. So if I do know you, apologies. But so yeah, there's been some good responses there. So good interaction.
Steve, the knee plica, I'd be very surprised on my knee experience if that didn't improve. But I'm not sure if that's an existing MLS user.
Is that, I think that was from Mary. So that's Mary's one of our AZA Laser superstars.
Right.
So yeah, and Mary has had some great success with the laser. So that's interesting on that particular one.
I'm happy if she communicates privately, because I've got some other things we could share there. And Catherine, someone's asking about that study from São Paulo and Brazil. I think you've got that, but I'll give Catherine the link, and if she wants to put that somewhere for you, that would be helpful.
Well, certainly what we'll do is we will follow up with a summary of these questions and some answers as best we can, and also a link to some of the research. And I will just share the screen in a moment, Bronwyn, with your special offer for people who are in attendance tonight. But if I can just thank our panelists, Kirsten, thank you so much for getting up early this morning before your Monday morning at work. I know that's a very, very generous of you to give your time like this. And also Bronwyn, the end of the day for you there in Sydney. And Steve, I'll just share the screen now. So thank you all very much. It's been deeply appreciated, all the expertise. So I'll just put this up here and show people the, let's see, where am I sharing the screen? Okay.
While you're doing that, a big thank you to you, Catherine. Thank you so much. I love the idea that we've done this. I love that we've brought this idea together. So that's great. Thank you.
Well, it's been really interesting and just fun to do it. We certainly, for those people who are interested,
then contact us.
oh, we have, oh, that's not what we want. Okay. Oh, Bronwyn, here we go. We've got demos available in most of the countries where we sell the laser, but also this is the special offer from Bronwyn. She has a clinical GEMS program, which a lot of our Australian clinicians attend, but we're opening this up worldwide, globally. Isn't that right, Bronwyn?
It is. And Catherine, I'm doing an offer. I've put together a special interesting and complex cases program, which is a freebie if you put in global web as the free access code. So go to drputsolutions.com.au/education. And that will be done at 8 p.m. in the UK time, Greenwich Mean Time, unless our change in daylight saving he's mucked that up, but in the evening, Thursday, the 8th of April, and maybe Catherine would be kind enough to send those details out to people too.
We certainly will. We certainly will. And we look forward to having ongoing conversations, and we'll say good night and good morning. And thanks so much for your involvement.
Thanks for having me.
Thanks,
Hey,
everybody.
pleasure. Okay. Bye-bye.